see.
Hi, everybody. Sorry to be a couple minutes late.
Hey, we wanted you to be. Hi.
Hi.
So everyone knows this is being recorded, right? Anyone that has any questions now can put them in the chat. And what I'll do is I start off with the questions that I already received. Naomi, I don't have another email from you. Unless I already got that. I might have.
I sent you 2 questions. Hi, Dr. Escalon.
Okay, hold on, I'll just keep this here. All right, Doc, you want to introduce yourself or should I? This is my awesome spinal cord injury doctor, Dr. Escalon. Everybody that knows him has him loves him. Woo-hoo! And he very gracefully volunteered to do this. I want everyone to know. I asked him questions like I always do. And he said, these are good questions, Natalia. Maybe other people have questions. So I really want to thank you for being so gracious, doctor.
Yeah, it happened naturally. It wasn't like Natalia's been after me for a long time. And we can, if you actually enjoy this, we can make it more regular.
Amen. Whew. Hallelujah. Yes. Love the sound of that. All right. So anything else you want to say, Doc?
No, so my name is Miguel Escalon. Like Natalia said, I'm one of the spinal cord injury, physical medicine, and rehab doctors here at Mount Sinai. I have an inpatient practice here within the hospital. It's relatively small compared to like Dr. Bryce and Dr. Wong, who take most of the patients, but I am taking some. And I have an outpatient practice at 98th Street and at 102nd Street.
Nice. Okay, cool. All right, and in case there's another person. Okay. In case anyone didn't hear me before, if you have any questions, you can just put them in the chat and I'll add them, okay? Okay. All right, Doc. The first question, I'm wondering how our spinal cord injuries will affect our bodies as we age. As we get older, what can we expect in contrast to our non-spinal cord injury peers, spinal cord injured peers, sorry.
Yeah, it's a really good question. It varies a little bit depending on your level of injury and involvement, right? So someone that has an incomplete injury and is walking around may be a little different than someone else that might have a more complete tetraplegia in some ways. I'll give some examples, like scoliosis, for example, can happen over time. If you have core strength in your abdominal and back muscles, that can kind of help prevent scoliosis. But if you have less strength or a lot of spasm in your core, over time, you can get scoliosis in your spine. So that's one example of something, and something to be on the lookout for. If you start to sit differently in your chair or maybe on your side, you're getting like some bruising or pressure on the side panels of your wheelchair, it may be a sign that your posture is changing. Something to talk about with your therapist or your rehab doc or the wheelchair clinic. In terms of like life expectancy, it's gotten pretty good in terms of like compared to how it used to be. A life expectancy of someone that has a spinal cord injury is basically the same as someone that doesn't. There are some nuances there, meaning like some slight differences depending on if you require a ventilator and you cannot come off the ventilator, then your life expectancy may be a little bit different. But for folks that aren't on a ventilator, really life expectancy is about the same as anybody else. So I don't know if that was part of the question, but I thought I'd throw it in. In terms of other things that maybe to think about, there may be wear and tear on your joints in ways that other people don't experience. So you may see like say you use a wheelchair or crutches or some kind of walking sticks, you may start to see wear on your shoulders, right? Where that may not be as usual in someone that doesn't use an assistive device for mobility because they're not needing to put so much pressure on their joints. So having a focus on and that can be different for everyone. It's just an example that I'm giving, right? If you're walking or not walking or using a wheelchair or not, in all likelihood, there's some muscle or some joint, whether it's your neck on your wheelchair, if you're driving with your head, or your wrist or your elbow or whatever it is that you're using in a way to just use like a cliche expression in a way other than God intended, right? So using it maybe more often or in a different way. And so you might be at risk in those spaces of developing pain or even arthritis. So it'd be something to keep an eye out for. If you're not sure, you can ask your doctor. You can even ask now. You say, "This is my particular situation. We can talk about it." But the other things to consider is bowels. As we age, our bowels naturally slow down. And so if you have a spinal cord injury where your bowels are already slowing from the spinal cord injury and you are needing to do things to help with the bowel routine, it's possible that over time you may need to do more of those things or change the way that the routine happens or change your diet to keep regular. That's not unusual. In terms of, there's not any difference. So in terms of like cancer rates or anything like that, none of that's different. That's the same as if you would have never had the spinal cord injury. I don't know. Give me a sense. Am I answering the kind of stuff you want to hear? Or am I like way off target?
I think it wasn't my question, but I think
Yeah.
you're answering it and much more, which is valuable information. Yeah.
Okay. So, I mean, just, keep peppering me with stuff along those lines. If I didn't hit something that you're particularly curious about, there really shouldn't be any long-term like cognitive issues or anything. Sometimes I get that question, like, am I going to get dementia from my spinal cord injury? The answer is no. Not unless you also had a severe brain injury at the same time, which sometimes happens, in which case we could talk more on this or offline, meaning in another forum. But yeah, so what's the other thing? If you have a high paraplegia, meaning like you technically have paraplegia because your arms are all the way strong, but you have your sensation say stops in or around your chest. Or if you have tetraplegia, you're at higher risk of developing pneumonia. And so keeping good, what we would call chest PT is important. So sometimes you might see if you're ever in the hospital and they banged on your chest or they gave you like a vibration vest or nebulizers, doing that regularly, even if you feel like you don't need it, not necessarily every day, even if it's once a week, I think is a good idea to keep your lungs free of mucus that builds up slowly over time. And some people need an assisted cough, which is kind of like a glorified Heimlich maneuver, or there are also machines that can do the assisted cough for you. Yeah.
I didn't know.
Yeah.
You brought up two things that actually leads to two questions. One, I think I actually have this question too. One, can there be instances where there is brain injury during a traumatic spinal cord injury that does not get diagnosed formally as a brain injury? And can that, meaning, I'm speaking from personal experience because I'm paranoid about my brain. My sister has brain cancer, so I get scanned every year. But I wonder if I have that. So the question is also, can it not show up at all as a TBI, but be a TBI due to the SCI?
I'm going to answer this briefly, but if it makes more questions, let me know. So the technical answer is yes. The likelihood of that being the case is very small, and I'll give you some examples. So if you, like I've had patients before get spinal cord injury, they were just standing in the water, they got hit by a wave and they had a bad arthritis, and then they had a spinal cord injury from that. In that scenario, say they had a mild concussion, that wouldn't show up on any CT scan or any MRI. But because it's mild, it should resolve. So does that mean you could have issues for a little while or a few months? Sure. If you have a history before that, say you played rugby and you had like 10 concussions before that, and that's the 11th concussion, then maybe that's a little bit of a different story. But if it's kind of the first time or an isolated incident, that type of example shouldn't lead to long-term consequences. There are situations where we have seen, like in high speed, like say a high speed car accident or something, someone gets spinal cord injury of their neck or their back, the presumption is anyone that was in that level of car accident would at least have a concussion just for like, even if it lasts just a minute. But a lot of the brain injuries that happen in those instances are severe enough for like a skull fracture or some blood on the brain that are very visible and get caught on the CAT scan. There is one form of brain injury that is on the more severe spectrum but wouldn't be seen on a CAT scan. And that's called diffuse axonal injury. But that's actually a quite severe brain injury. You know, probably you or whoever would have that would have severe cognitive deficits that would not be ignorable. So it's not like, oh yeah, my memory is a little bit off, but I'm talking fine. Like you would have really noticeable deficits, but it's possible it could be missed, you know, and you could have been in a coma for a month and nobody would have understood why. Because for whatever reason, the CAT scan doesn't pick that up. Only a very special kind of MRI does.
So did I hear you say that concussions can have long-lasting effects or no?
They can, you know, think of the NFL and you see like all these people that get like many concussions and then they develop. So, you know, if you had a spinal cord injury, you had a concussion at that time, but there was no blood on your brain and you recovered, there should be no long-lasting issue. But if you, I don't know, say you like to box or you were always clumsy and you were always hitting your head even before, and you'd had concussions over time, then it's possible that if you had a concussion during the spinal cord injury, it could be like a tipping point or a straw that broke the camel's back kind of thing.
Okay. All right. Thank you. Okay. We talked about when you were talking about bowels. So for people who have been injured a long time, that have gone through everything, the Senna, the Colace, Linzess, Zocalox, everything, the suppositories, magic bullets. I have someone that says that none of these things are working anymore. And even the digital stim is not as effective as it used to be. And they're asking specifically about a drug called Peristine.
So Peristine is not a drug, as I understand it, it's a system. So it's like a device. So let me answer one thing quickly, and then I'll talk about the Peristine. So one thing that you should always keep in mind, you know, I mentioned like over time your bowels might change, right? But if your bowels are changing in the context of other things changing, you should let someone know. Meaning like, hey, my bowel routine is taking a lot longer, and also the feeling in my feet or legs is different. Or, hey, my bowel routine is changing and my spasms are a lot worse. Or, hey, my bowel routine is changing and my bladder is also changing. Because there are sometimes things that can happen within the spine, even years later, that could account for those changes that sometimes are correctable. And so there may be, even though the answer might just be, this is your body changing over time, there's nothing we can really do besides try and find something better for you to manage. There's a small percentage chance that there's something going on that could be correctable. So it's worth bringing up if you're having those issues. The Peristine, gosh, for lack of a better way to say it, is like an at-home colonic. So it's kind of like a self-enclosed enema. So it's like a bucket of water thing that hooks up to a tube that goes in your rectum, and the balloon is inflated. And then there's like a machine by which it shoots water into your colon to basically do what a colonic does, which is kind of wash out any poop that's there. And then that poop falls back into the machine that has a bag that then can empty into a commode. So the problem with the Peristine is the insurance doesn't always cover it. If you have crime victims or some other kind of insurance, sometimes it'll be covered like kind of no questions asked, like workers' comp. Sometimes it's pretty easy. Otherwise, there's some paperwork we have to go through and we can try. And sometimes they say yes, and sometimes they say no. And the other thing is, depending on your level of injury, it may be difficult to maneuver on your own. So it definitely takes some manual dexterity to kind of like a little more than even a traditional bowel routine, because you have to not only be able to insert the catheter, but like inflate the balloon and stuff like that. So I've had some patients that have tetraplegia that were doing a good chunk of their bowel routine on their own, not be able to manage the Peristine on their own. So that's something to keep in mind. The Peristine company, as weird as it sounds, don't quote me on this one, I know I'm being recorded, but I feel like they would come out and like show you how it works if you call them, or they'll have videos that show you, so you can get a better idea before you were to actually purchase it or anything.
Okay, thank you. This is a two-parter. Will burning nerve pain ever subside or stop? And do nerves regenerate over time?
Maybe. So burning nerve pain can subside over time, but it sometimes it doesn't. And there's no good test that we have. There's no MRI, there's no EMG, there's no blood test that I can really do to say like, okay, Natalia, you have this special kind of nerve pain based on this blood test, and I know it's going to last like a year or 5 years, but it'll go away eventually. Versus say, hey, Natalia, this is just what it is. Unfortunately, we don't have that. It's hard for me to say yes or no. I will say it can do funny things. I've had patients where the pain has gone away. I've had patients where pain comes, years later, or starts and go whatever, that it feels like burning, and then 5 years later it starts to feel like cold, and all these weird changes that happen that I don't have a good explanation for necessarily. If new pain comes over time, and it's getting worse, I always check an MRI or a CT of the spine just to be safe. But if that's okay, then sometimes we don't have an explanation. I always look at bowel routine, bladder, pressure injuries. There, even stress, like emotional stress. Any stress on your system can make your nerve pain worse. And so that's another thing to kind of look and see, like, even if we can't get it to go all the way away, can we make it, if it's a 7, can we get you to like a 5 or a 4 or something that's manageable? And then the other question was about nerves regenerating.
Yes.
So that the technical answer is yes, but the answer that really matters is, can they regenerate in a way that fixes the problem?
Mm-hmm.
So the nerve, if your spinal cord is totally cut in half, then that becomes a lot more difficult for something to regenerate across kind of that gap. But as long as any part of your spinal cord is intact, the nerves will try to regenerate. The problem is it has to be regenerated in like a very specific way, like a piano, right? If you connect the wrong string to the wrong key, it's not going to work the right way. So this is like a piano times a million. So the nerve basically has to regenerate in exactly the right way, which is very rare. If we're talking about the spinal cord, there may be some people on this call that have a lower motor neuron injury, which means the injury is not in the spinal cord, but like in the cauda equina, which are the nerves that come out from the spinal cord at the very bottom of the spinal cord.
Oh, okay.
So that could be you if you don't have spasm, if you have strength kind of in your upper thighs, but not at the knees or the ankles, and your knees or the ankles are more loose. That could be, you might have some cauda equina. In those cases, we have seen if the nerves are intact, there's a little bit of there's a like a highway or road for the nerve to travel down. So sometimes those will regenerate. It just depends on the initial injury and whether it left enough of like a root of the nerve to kind of try and regrow out following that initial highway. Otherwise, that highway can die and like fall off, and then the nerve has to sprout and try to find its way on its own, which it's not very good at doing.
And then so for the people that the nerve pain did subside over time, have there been any studies or stats about there being a common thread? And I'm talking about people specifically with spinal cord injuries.
No, not at least not that I'm aware of. I mean, there's a lot of research going on in pain in terms of treatment and trying what the doctors would tell you that is what you're asking is there research on phenotypes of pain or different types of like different sources or generators of the nerve pain. I know that Dr. Bryce has been big on creating a module within the model systems to try and track this, like everyone's pain and what it feels like, how long it lasts, does it go away, what medicines worked, so that hopefully down the road we have enough data to pull it together. But we're not at that point yet. But, you know, in theory, that's coming, at least to a point where, you know, I can't promise that we'll know every little thing, but at least to a point where we know a good chunk more than we know now.
Amen. All right, next, speaking of studies, are there any studies or research for the effects of SCI and sensation changes? And what timeline might be expected for improvements to temperature, pain, and tactile sensory abilities below level of injury?
That's an excellent question, because the majority of the research is in and around function, right? So you might have, if you're ever online and you've Googled spinal cord research, you've probably seen like this electrical stimulation stuff that they're doing, and they're doing some in Kentucky. And I think that project has some satellite campuses, like there's one in New Jersey and stuff. And they'll, you know, they put a stimulator, like a pain stimulator, in your back, and then they try to, but really what they're looking at a lot of things, but their main outcome is really your strength. So it's an excellent point, because the sensation tends to be a little bit of an afterthought sometimes when these studies are built. So I would say, relatively speaking, there are few where that's the primary thing that they're looking at. Like sometimes it's like a secondary, like, oh yeah, and we'll ask about sensation, but we don't care about it as much.
Mhm.
You know, I would say that you might have some power there, though, in dictating where future research goes. Like if you reach out to places like the Christopher Reeve Foundation or the Craig Nielsen Foundation and say, hey, these are things we care about, because they're the people that give the money to do a lot of this research. And so you can, even though you're not the one, you know, like talking to the doctor, you could go around them and say like, okay, well, if you're not listening to me, I'll go where the money comes from. And then they can put out research about what matters, because, you know, those foundations really are, I think, meeting people that run them really do their best to try and represent and the consumer, which would be anyone with a spinal cord injury. But without feedback, they won't necessarily know where to go. A lot of the research now is really pushing on a cure, quote unquote. And so sometimes the things that would help your life be better today are left by the wayside.
Okay, so it's not getting looked into much, but hopefully it can, and we can help do something to try.
Yeah, you can advocate.
That's a good idea. I never thought about that. That's a good idea. Oh, I want to ask the question, well, that prompted this, right? So, okay, the relationship between the Asia scale and the complete and incomplete diagnosis, and can your diagnosis from complete to incomplete change to the other? Like they told me I went from complete to incomplete, and can your Asia scale change? And isn't there another way to check your Asia scale other than pricking you in the ass? We gotta
So,
find a better way.
yeah, so eloquent as always, Natalia.
I get
So,
it, Doc. I get it.
yeah, no. So let me explain.
Yes.
The Asia exam is not perfect. The Asia exam is a research tool. And so it was invented for researchers to talk to each other and to try their best to communicate a change in sensation and strength. So I'll give you an example of what I mean. Like, arguably, the most important muscle group for someone with paraplegia or tetraplegia is shoulders. Doesn't matter what your hands are doing or what your elbows do. If your shoulders don't move, you'll be a T-Rex, right? And so, but guess what? They don't test on the Asia exam. They don't test your shoulder strength. Nope. And so the thought process behind the Asia exam is really about a research communication tool. Now, the reason that the last part of the Asia exam involves the rectum is because for the most of your body, like the spinal cord in your neck goes to your arms, and in your like mid back goes to your abdomen, and your low back goes to your legs and your toes. But the very bottom part of your spinal cord is not what goes to your toes. It goes to your personal areas. So the reason that that's the reason that your personal area is checked. Now, the reason that they check the rectum preferentially is because it's much easier to check for spasm and reflex there. It would be much more difficult to do that checking the other part of your anatomy or personal area. So it's always within your purview to, it's always within your purview to say, I don't want that part of the exam. But just to explain, when the exam was being made, why that thought process is there. We did do a study a few years back to see if we could figure out whether if we asked people questions like, hey, when you pass gas or you have a bowel movement, do you feel it? Can you hold it in? Questions like that, like if it was the same amount of accuracy as doing that part of the exam, so maybe we could skip it. And the answer we found was over time, like when someone had been injured for a while, it was pretty accurate. But in the hospital, it wasn't always so accurate to ask those questions. And that makes sense because people's bodies are changing. Mm-hmm. To answer the first part of the question, your ASIA score can change every day. You can go from being complete to being incomplete. Complete only means that when they do the rectal exam, you don't feel it, and you can't squeeze your anal sphincter. That has nothing to do with whether you're walking or not. You could be walking and have a complete injury. Complete only is about the rectum. So I want to make that very clear. So a lot of people feel like if you're complete, then that means nothing below the level of your injury can be moving or have feeling, and that's not true. There's a lot of technical stuff, like I can have a C4 tetraplegia, which that is complete, which if I said that to some of you that are good at, like, really have learned the ASIA exam, or another doctor, they might imagine that that means I have no movement at all below my neck. But this is where things get confusing. There's something called a zone of partial preservation, which is a fancy term for basically saying someone is an incomplete complete. So I can have a zone of partial preservation to C7 or T1 or whatever, and still like move my arms or my legs. So the reason I'm saying all this and getting a little technical is to let you know what matters most is what you feel and what you move. It doesn't quite matter as much what I tell you that you are score-wise, right? So if you're improving over time, that's what matters. If you're getting worse over time, we need to know right away so we can try and help. But there is, the flip side to that is, will you say, well, the doctor told me I'm ASIA A, so I have only a 5% chance of walking again or something like that. ASIA A being complete. Well, that data is a bit old at this point, but it does exist. So if you're the kind of person that really needs to know those things, you could always ask. But the truth is, there's no doctor that can tell you, short of your spinal cord having been totally transected or cut completely, there's no doctor that can tell you what you're going to look like in a year from that point. It's just guesses. And I've had people that I thought were going to walk and do great that didn't really get much better, and the complete opposite, where I was like, oh my gosh, like, I hope they don't end up stuck in a nursing home. And then they did really well. So as time passes, your rehab doctor will get a better idea. So once you've known them for a few months, 3 months, 6 months, they have an idea, where you could end up, even if they don't want to share it. But those first couple of months, there's nobody that can tell you.
Okay. From my experiences, I've noticed that when people have told me that they're incomplete and I see their level of function, I usually see the people that say incomplete, like I'm talking quad life now, that's my life, that they have more function than the complete. So I was under the impression that complete meant complete severance of the nerves in the spinal cord, as opposed to incomplete, where there's a little bit that can kind of get through. So that was totally wrong.
Well, I don't want to say that you're wrong, Natalia. You're never wrong. But there's an idea, like, I just want people to understand, like, when a doctor says complete, they're not talking about anything besides your anus. But when you speak to each other and you say, I'm complete, that might mean something different when you speak to each other, because you might be using complete in a different way. But when we speak to each other, we say complete. So there's an idea of people, like sometimes I'll say patient is discomplete, which means they're basically incomplete, but they just don't have any feeling in their rectum.
Ah,
So there's all kinds of like weird in between. But the key here is like, how do we find a way to communicate where you were and where you are now in terms of strength and sensation? So the Asia score kind of is what it is, but it's the best that we have.
okay. Is there a difference between the nerve pain that we with SCI experience and fibromyalgia?
Is there a difference?
Yeah.
Yes. Fibromyalgia. And so this is something that can become difficult after a spinal cord injury, and I'll explain. But fibromyalgia involves an exam where in a certain number of places, pain can be triggered with certain maneuvers in those parts of your body. So because it tends to be like a whole body type of pain without getting too detailed. So it doesn't come, so as far as I know, a spinal cord injury would not trigger fibromyalgia. Could you develop fibromyalgia after a spinal cord injury? In theory, yes, because it comes from a different place. It's thought to be something, from within the body that would have happened regardless, right? So, but the question is then, how is it diagnosed? If you don't have feeling in those parts of the body that require us to do maneuvers or different sensory tactics, right? If I touch your ankle and it doesn't cause pain the way it should, then technically I can't diagnose you with fibromyalgia. I need a certain number of spots. So what you need is a physician, a pain doctor, a rehab doctor, whoever that would be open to the idea that you could have fibromyalgia, even though you don't classically fit the picture. The treatment for fibromyalgia usually are antidepressant class medications. Some of them are pretty common, like Cymbalta, you may have heard of and might have been on. And some are less common, like Savella, where your doctor may or may not have had experience with it. But those are basically the medications that are used for fibromyalgia are very similar to the ones that are used for nerve pain. A few antidepressants, and then if those don't work, some of the same medications for nerve pain. And cognitive behavioral therapy is a big part of fibromyalgia, as is exercise. Those are two mainstays. Usually without those, even with the perfect medication, the pain can be difficult to control.
Okay. Right, that leads into the next one. So any recommendations for pain management for chronic pain after a tethered spinal cord? I don't know exactly what that means.
Yeah, a tethered spinal cord is when the spinal cord gets twisted or stuck to the side of the inside of your spine.
Ooh, okay.
And so that can happen with scar tissue, like after a traumatic injury or surgery, you can get scar tissue there, and then that scar tissue becomes sticky. So the spinal cord could stick to a bone or a ligament in your spine and then get pulled and taut. So if the spinal cord is tethered actively, like right now it's tethered, the pain management usually is around initially nerve pain meds like gabapentin or Lyrica or Cymbalta. Sometimes stronger pain meds, but it's not something that I typically like to do, like say like morphine or something like that. I don't typically like to do that. Sometimes we can use tramadol, which isn't quite as strong and has a little bit of nerve pain function. But if we're trying meds and it's not working, then usually the solution for that type of pain is a detethering, a surgical detethering, basically like scraping that sticky part off and letting the spinal cord be back in the middle and floating around in the water, the spine water, that cerebral spinal fluid that it lives in. And then that oftentimes will help get rid of a good chunk of the pain. If you have already had that surgery and the pain went away and came back or never got better, then I will re-image just to make sure it didn't get tethered again, which I saw happen in one patient. Or we need to stop and think about whether or not the pain was coming from somewhere else. Like the pain after spinal cord injury is really difficult. Like if I took, I'm going to use you as an example, Natalia. If I took right now, I have a hammer and I take it to Natalia's knee and I break her knee, she might feel that as numb, burny, tingly. And so I might give her gabapentin, but that's not the solution. Her pain is actually what I would call in doctor lingo nociceptive, or coming from the bone. It's nothing to do with the spinal cord. So really what she would need is like Tylenol, ibuprofen, maybe a dose or two of morphine, and maybe surgery to fix the problem, right? So when we look at and we say, okay, we think this is nerve pain, it's sometimes hard to be sure. So if I've given you all these meds for nerve pain, it's not helping. We've tried it. There's nothing else to try. It's worth taking a step back and say, is there anything else? Like, do I need a new cushion? Is there something else that could be like leading to me having this pain that I'm feeling feels like nerve pain, but it may not be because nothing else is helping it even as a smidge. How can you maybe tell the difference? Nerve pain is often constant, means it usually is always there. Sometimes it's a little worse, sometimes a little better, but it often doesn't go away. It can be also, you can be like hypersensitive. So like if somebody were to barely touch your skin or something, that would be super painful. So regardless of what the pain feels like, those are two hallmarks of nerve pain as we think of it on the doctor side. Other types of pain might be more like when you're being moved. So I only get numb and tingly when they move my knee. Well, that might not be nerve pain. There might be something going on with your knee. So sometimes we just stop and think about, okay, well, what are the pain triggers? Let's keep a little bit of a pain diary, and let's take a little bit of a step back and just see like what makes sense here in terms of like what besides the spine could actually be generating this pain.
Okay. I should have brought this up when we were talking about the bowels, but as we were speaking about how the body changes with age, with time, is it common for us with SCI as we age and our intestines age to perforate? Does that come with time and age?
Or what to perforate?
The colon, the intestines?
No, I mean, the answer is no. Like this, there's nothing that's from the spinal cord injury that will make your colon like more likely to burst or perforate. But if you don't have good control of your bowel routine and you're often constipated and you're really, really backed up, that can stretch on your intestines, right? And so I think, so the answer is no, but the answer also is it doesn't mean you can ignore your bowel routine.
Is there anything out there to regain bowel and bladder sensation?
Sensation, there are like stimulators, like perineal stimulators, perineal meaning like in and around your personal area. They're implanted devices that they attach to those nerves that you can turn on. And supposedly they would help you control your bowel and bladder and maybe give help with sensation. But I don't have many patients that have done it, but I don't think I have a single one that was happy with it. So I don't know if they work that great. But in theory, there is something. So what I would say is if it's something you're interested in, with any of these implanted nerve stimulator things, like a spine stimulator or anything else for pain or that kind of thing, they can usually implant just an electrode before they actually implant the device. Now, in your spine, that's a little easier because it's kind of like doing an epidural, and they can tape the thing to your back. In your personal area, it may be kind of harder to kind of leave something in and like tape it up. But in theory, I think somebody could ask about that. But there's not like if you have no sensation and no control, there's not a good answer for your question. If you have a more incomplete, right, in quotations, because we talked about earlier, injury, and maybe you have like some sensation or here and there, like you get a sensation or things like that, you could always think about like pelvic PT. It's a little different, it's a little out there, but it's something to think about. So there's some thought that if you have some sensation, different techniques to kind of stimulate those nerves to regenerate more in that area could be helpful. But I say it's a little different out there because oftentimes it involves manual internal therapy. So this would be like inside your vagina.
Mm-hmm.
So it's not a normal type of therapy, and you should know before you do it that that's what it is, so that you're not caught off guard and that you are prepared and sure that you really want it, because it's also not a guarantee that it would work.
Yeah, I just want to tell y'all, Dr. Escalon gave me the same recommendation, and it was extremely awkward. It was extremely awkward. But I will say that because my issue seems to be from like a tight muscle or tendon, so, she'd manually be in there kind of rubbing it out, for lack of a better term. And for like a day or two, I'd feel good, but the awkwardness just trumped the pain relief. So good luck to anyone.
Yeah, and it didn't last, right? So,
Oh.
so I mean, the detective in me would want to say like, well, if the person could pinpoint the muscle, then maybe we could figure out a way, like under ultrasound, to Botox it, like not going through the vagina, but like from a different angle. So, but again, it's all, I wish there was something I could say like, yes, this is the answer. If you have, some people have like some sensation, like if they're having intercourse, they say like, I have some sensation, I'm not achieving orgasm, or maybe I do with like clitoral stimulation, but not like with penetration. And, as long as it's not painful, sometimes it's kind of like any part of rehab. Like the more you do it, the more your body might be able to regenerate. So it's easy for me to say like, if you do something that you're supposed to be pleasurable and it may not be in that moment, and like all the psychological impacts that might come with that. But the truth is like, that I have heard that like, okay, things maybe weren't the same, but the more I did have sex, like the more I was able to find something pleasurable about it. So I would just throw that out there.
Well, now that you took it to sex, it wasn't my fault this time. Are there any studies that show that with more stimulation to the genital area, not psychologically, because I know what you mean by that, I say it all the time, that a lot of people are overly concerned with not having actual sensation, but sometimes the act of sex involves a whole lot of other things. So I always encourage people like sex as much as you can. But so yeah, the question is, does this show that like physically there's changes with more stimulation to the area?
I don't know. I can look and check if there's research for physical like changes. What I will say is, after a spinal cord injury, you can still get a sexually transmitted disease. So be mindful. I've had some patients that thought they couldn't, mostly men, but I use it in this forum also.
I always think that way. That is
yeah. And you can still get pregnant if you have not gone through menopause. So you just have to keep that in mind. Like it's not, sometimes initially after an injury, your period can go away for a time and then become irregular before it normalizes. In that period of time where it's irregular, and after that when it's become more normal, or even if it stays irregular, you still could get pregnant. So you just have, like, if you're not in a point in your life where you want to be pregnant, you have to use some kind of contraception.
Yeah. And I think that it's just personal experience again. I think that it should be noted more that people with spinal cord injuries tend to clot, and so they shouldn't be prescribed lots of kinds of birth control, because you can have a pulmonary embolism like me. Like that should be something that's known more.
Well, I think that's fair. So what I would say, like in a couple of patients that, this could happen a lot more where it doesn't. Like I will often tell you, if you're my patient, hey, I need this help with something, and I'll say that's for your primary care. You need to get a primary care doctor to do that. but at the same time, like there needs to be some better communication in some phases. So if you have a spinal cord injury, the first 3-4 months after that, you're at higher risk of clots. In theory, after that, your risk of clotting is the same as anyone else, but there are lots of caveats there. Like if you've had a clot, if you ever had a clot, you're more likely to have a clot. If you're sick, say you're in the hospital, and you're on complete bed rest versus even if you don't have much movement, if you're up in the chair and getting, transferred and stuff, you might be at higher risk. But there are certain instances where, yeah, there are things that can increase your risk of clotting that doctors don't always tell you about. Certain birth control is one of those. If you start to get headaches and you're on birth control and the headaches are new with the new birth control, you have to stop it right away. There have been studies that have shown strokes with birth control that first appeared as like migraines. And just know that, yeah, I see your face there, Natalia. So it's the same kind of thing though, increased clot, right? A stroke is just a clot, but in the brain. So if you are worried about clotting, but you want to be on birth control, you just have to say like, listen, and your OB or your primary care is not going to know. So you just tell them like, hey, I'm at higher risk of clotting from my spinal cord injury, whether that's a little white lie or verging on one, that's okay. And then they'll just be a little more careful with you when they prescribe you things.
Cool, thanks. Oh, this came from a physician. How can physicians better advocate for their patients when it comes to getting the right equipment for a better quality of life?
Oh, goodness. Well, I'm just saying, oh, goodness, because the insurance companies make it so hard. I can't tell you how many times a week I write like something, let's just use like a hospital bed. Like I'll write a prescription for a hospital bed and a letter of medical necessity, and I'll send the chart notes. And then the insurance company will say like, this one little thing was wrong. And I'll redo that one little thing. And then they'll say, but you didn't resend everything together. Then I'll resend everything together. And then they'll be like, well, the prescription you wrote initially has now expired. And I got to do the whole thing again. And they're like, well, now it's been like 6 months since you saw Natalia. So you got to see her again.
Mhm.
And it's like this, where they like make everyone, it's worse on your end, I think. They make everyone jump through so many hoops all the time. So I would say, if you ever need something that's called a fair hearing, it's, if you haven't heard of it, it's basically where you petition like the insurance company to the state, and then that the insurance company is not meeting the standards that they should. Everyone that I've seen do a fair hearing has won.
Mhm.
I've never seen them lose because
Yeah.
they're always right.
Yeah.
They're always like, well, I need a wheelchair or I can't move. And the insurance company is like, no, you didn't document this one little thing. And then it goes to the judge and the judge is like, this is ridiculous. Give the wheelchair yesterday.
Mhm.
So that's something. But I think the other thing is just, gosh, I hate to say this but I'm going to say it anyway, at the risk of coming off a certain way. If you can, when you message the doctor, tell the doctor exactly what you need. And so that it minimizes the back and forth that the doctor has with the insurance company. That would help you get things faster. From the doctor's side, I think understanding that, and like if you're not clear, reaching out to the patient. So sometimes somebody will say to me like, hey, I need a hospital bed. And I'll send them an email or a call them, be like, hey, Natalia, don't you also need like a letter of medical necessity or something else too? Natalia might say, I don't know. I say, do you mind talking to your insurance company? Because I don't want to go like this whole thing. So I think from the doctor's side, I think just understanding how things run is important. And also if you have patients that are uninsured or underinsured, understanding where you could maybe go. Sometimes a place like Wheeling Forward, or there are other places that might have donations for certain types of equipment. And it gets even more complicated with like catheters and all this stuff.
Mhm.
So I think that's another place where advocacy would be helpful, because insurance companies are often trying to cut costs. I mean, I've been emailing with somebody all day who's been out of catheters paying cash for like a month. I've sent the same thing. I sent the chart notes. I edited the chart notes. I sent the prescription. I edited the prescription. The urologist is doing the same thing, and they still haven't gotten them. So I think if the more we can communicate about it, I think the faster things will get done. The more we'll each learn, like the doctor will learn more about what your needs are moving forward. So the next time it'll be like more smooth, and vice versa. I don't know if I answered the question. Hopefully I did.
Yeah, you did. So
Natalia, I think I have to meeting at 4, so I maybe have time for one more question.
I know, yeah, that's exactly what I was gonna say. I have one more question. All right. What are your thoughts on using Bulkamid for stress urinary incontinence in people who have no urethral sensation?
That's the filler, right? I think that's the filler.
Sounds
So
like
the filler that you get in your face is the same filler that they would put in your urethra. So it's okay. I mean, it doesn't last forever. Like the fillers in your face, it goes away, so it needs to be redone. So the idea here is, if you are someone that is having incontinence and does not want incontinence, and then the filler is a consideration. There's a lot of layers here. You know, you may still need a medication to keep your bladder relaxed, depending on the pressures within your bladder to keep them safe. And if you're somebody that needs to catheterize, having the filler won't keep you from needing, you'll still need to catheterize.
Mhm.
So, but the filler would just mean like you could hopefully stay more dry in between caths. So, you know, I have some patients that have done it. Usually we don't go to do that until we tried just some oral medications first. But it's there, you know, like it's possible maybe we should be using it more. What was I going to say? I think that's it.
Okay. Perfect.
Right. So if there are more questions I get to, I'm sorry, but like I said, I'm happy. You know, we can set another one of these up.
Yeah, this is great.
Yeah.
Thank you so much. Thank
Yeah.
you. I love
Hopefully,
you. I appreciate you.
hopefully some people got something out of it. So thank you for showing up. I was worried it was going to be me and Natalia.
Hey, that would have been a good time anyway.
Thank you, doctor.
Thank you, everyone.
Okay, thank you.
Doctor,
Bye.
thank you so much. I'll see you soon.
Yeah. Bye.
Thanks, Dr. Escalon.
Yeah. Good to see you.
See you
Adrian.
soon. All right.
Yeah. Bye.
Bye, everyone.
Bye-bye.
Bye. Take care.